I feel humbled and privileged to be here to talk to such a varied audience, and bear in mind I'm used now to primarily talking to and trying to indoctrinate clinicians, so I'll do my best to do the same to a wider spectrum. The title I've got is Bored, and I want to really give a very personal view. This is not necessarily a trust view, a personal view of where we are currently with the evolving healthcare landscape, and why standing still is not an option, but radically what I would call revolutionising what we're doing at the moment, not evolutionary way, but a revolutionary way is absolutely key. And I think whilst there's lots that's good, and there's a general increasing consensus about convergence of people not working in isolation, fragmenting care, but actually starting to move together. I put before you an outpatient from central Middlesex over 200 years ago. And what I would say when I wander out into the outpatient area at UHCW, where I work in Coventry, is that not a lot has changed, apart from the dress code. It's an antiquated, paternalistic approach to delivering care. If your car breaks down, you can often get somebody to come to your house. If you need your car servicing, you can often get people to come to your house and take it off you for your convenience, at your convenience. If your plumbing goes down the tube, you don't wait 7 months for somebody to come in and fix it, and nor would you tolerate that, you'd go somewhere else. But they come to you. And yet from a healthcare point of view, we expect patients and the vulnerable to come to us. And we've got to change that. Now, it's Christmas. Christmas feels like it's come early this year, but for those who want to, I'm going to intersperse a few slides with a rheumatology slant, but it's medicine, it's partly historic, it's partly innovation, and it's partly trying to show that we've got to learn from our ancestry, but also look to the future. So I'll just leave those words with you, and you can make a decision. We'll revisit it later on, but quite a graphic description of gout. I'm not going to ask anyone who's participated or suffered from being afflicted with that condition, but with Christmas and New Year coming on, I can guarantee the likelihood of an increased incidence is certain. So at the moment, we have fragmented healthcare, and delivering an electronic patient record with a patient portal that enables a patient to be informed of and contribute to their health and healthcare is a must. It's not a luxury item. It will be considered a given in 10 years' time. It's just how we get there and how quickly we get there. Because at the moment we have isolated mounds of paper supplemented by increasing numbers of disparate IT systems, with every specialty thinking they're the most special specialty and in their own specialised system, which doesn't necessarily interoperate or talk to all the other systems. And what that leads to is the react-respond NHS we have today. You only have to turn on your radio or listen to the news on a daily basis to know of the current crisis. But the crisis is no longer a crisis, it's part of the norm. I remember red alerts and black alerts 18 years ago. They were genuine one-off events that would happen only a few times a year. Our trust, and I know lots of trusts around the region and nationally, are on constant black alert with a control command, because patients use ED as a drop-in centre and there's no way to get the flow through. We've got just antiquated ways of working, and it becomes reactionary, episodic, poor quality, with poor outcomes, and just leads to further reattendances to healthcare providers, be it in the community or in ED. And what we need to move towards is taking all of the huge amounts of data. Certainly our trust has got millions of bits of data, really valuable data, which would probably support 15 PhDs, but very little of it is meaningful information. And what we've got to do is take the data we've got, connect it all together, and start using it in a predictive, proactive way, so that we can use genomics, genetic data, use the genome to actually start personalising medicine for the individual, but equally look at populations at large and use predictive analytics to know who we need to engage with and when. And that's the only way we're going to reduce variation in delivery of care, improve quality and reduce cost. We've had a strategy for the last few years to deliver an electronic patient record, but it's become far more of an innovation and transformation program. And it really isn't just about an electronic patient record, although everything is enabled and predicated on it. But I'm clear that it's all about the patient ultimately. The patient is at the centre of everything we do. But there's also a key bit about the infrastructure you need, the clinical change. These are clinical processes that need completely transforming, and therefore clinician engagement and leadership is key to enable the business models to completely change. But we have to remember, it is all about the patient. And that tagline has been a feature over the last 18 months as I've gone around various specialties in our trust and wider afield, constantly reminding them it's not all about the provider, it's about the patient. And it's really important that we remember that. Because at the moment, a patient's journey is completely fragmented, without flows of information, which means that patients are repeating what they say, how they say it, numerous times. We counted 53 times, and we stopped actually at that point because I was called silly, 53 times that patient demographics had been recorded by different people in different processes for an elective surgical admission. 53 times, utterly ridiculous. And we wonder why Chinese whispers occur. Now, when I talk about it being, and I'm sorry, just the technology has nicely come to my rescue and failed. But this patient has consented, and I'll talk while you look. But I want you just to imagine right now, and apologies, no insensitivities intended for anyone who is already suffering, because there's huge amounts of suffering out there. But on the assumption that you're all reasonably healthy, I want you to imagine this morning not being able to get out of bed, or taking until lunchtime to start to loosen up, needing help with the basics of activities of normal living, such as feeding yourself, toileting yourself, washing yourself, dressing yourself, getting up out of the chair to go and refill to get your coffee, etc., jumping out of the car and running for the meeting. All of those things, I just want you to imagine not being able to do that. And this was somebody I saw, as you can see, 6 years ago, and took one look in the waiting room. It's the only time I've ever done this, but I did actually send her straight to medical illustration en route to be admitted to our ward. And she was an educationalist working in the prison service who'd not been able to work for 4 months and had had symptoms for over 7 months and had been bedbound and confined to a downstairs makeshift bed for 4 weeks prior to being brought in by an ambulance to come and see me. Now, she was a severe case of rheumatoid arthritis, but 7 months in this state is not anything that any of us can be proud of. It's something that is completely avoidable. And as I said earlier, you wouldn't tolerate your stereo, your phone, your car, your plumbing, your central heating, a broken window, being in that state for 7 months. You wouldn't even allow your pet to suffer like that for 7 months. And yet we, on a daily basis, have to be honest with ourselves that this is a story up and down both this country and globally. There is huge amounts of unnecessary suffering. So I admitted her, and I think more than my words, a picture tells a picture is a thousand words. But this was just 3 weeks later after we treated her, and it doesn't matter what the treatment was, but it was about there's somebody with a health problem. I know what the problem is, and I can treat it, and I treated it quickly. Now, I could have treated it far more cheaply if I'd have seen her a week after her symptoms had started, or a few weeks after her symptoms had started. And our aim nowadays is to treat within 12 weeks. From my point of view, even that's not acceptable. We should be getting this treatment into people as soon as possible. And to not do so is just tantamount to negligence, really. So I just wanted to share that with you, because it's a powerful message, and really important that we appreciate the scale of the problem we're facing. This is a famous Time magazine front cover dissecting a $63,000 bill for somebody having coronary artery surgery. And it just makes you realise the number of people who come into contact with patients. And it's really important that we recognise the need, and this is just within hospital setting, and it's far greater when you look at community settings and primary care. And it's just so fundamentally important that we start singing from the same hymn sheet, sharing the same information, so we record it once and only once. And we have the mantra of everything, anytime, anywhere. This is what we're faced with now. I work in one hospital where we've got basically a lot of electronic, another hospital where we still have huge amounts. This is just one day's blood results for monitoring patients with rheumatoid arthritis on chemotherapy drugs. I do that electronically in one hospital, and it takes 20 minutes. If you look through that lot, it takes 3 hours. The benefits of going paperless are huge, both in terms of time efficiencies, but in terms of cost. And when you've got a myriad number of paper requests, it's no surprise that patients come back 4 months, 6 months later, not having had their tests. We would not leave our car in a garage and go back 4 or 6 months later and expect it not to be fixed. The whole way we predicate our services right now is so antiquated and paternalistic, it's not true, but it's inefficient. And it needs to poor quality. So we need to move and really catch up. We certainly need to catch up with our colleagues at the other side of the pond. We've got this dichotomy that primary care in this country, in terms of its digitisation and the use, EMIS, 1982, it came to fruition, are so far ahead of the game. They're seen as a global exemplar of good practice. The opposite is true in the States. But here in the UK, our hospitals are all pretty much a mixed economy of paper and various maturity levels in terms of digitisation. The opposite is true in the States. So we've got this dichotomy, and we need to play catch-up, but join up with our primary care colleagues and catch up with them as well. Now, I'm a keen musician, and I would love nothing more than, I love all genres of music, but I was classically trained, is what I should, becoming a doctor, and I still like listening to my Lynn turntable. And LPs are making a comeback, and most new recordings now have, of all genres, will have an LP. But what we need to be doing is what Steve Jobs did in terms of the disruptive innovation over the last 13, 14 years, in particular with the iPod. It's transformed the way we listen to, store and retrieve musical information. And we need to do the same with the paper record, with the health record. We need to transform that in the same way. Because you do it in your normal life. Before you go to work, you will do your online shopping, you'll do your tax returns, if you want a passport, you name it, it's all done online. More than 60% of people bank online now. And yet you go to the hospital workplace and we're all looking around for bits of paper. And it's got to be focusing on the patient experience. And what I would say is citizen experience. We are all citizens, and actually I want to propagate a vision of health, not health care on its own. We've got to focus towards prevention, and therefore people contributing data about their health is really, really critical. And we need to make it social, mobile and easy, because we've got a new generation coming through. My son can do things on an iPad and an iPhone, age 5. I've no idea how he does it. I'm not technical. I'm a clinician first and foremost. But he's really good, and the generation coming behind us can all do this. Our junior doctors can all do this stuff. So, pioneering integration of health and social care, it's been a buzzword for decades, but it's become a real sexy topic over the last few years, and it's where lots of work from the Department of Health, the Prime Minister's Challenge Fund, is all being targeted. And there's really some good examples of where work's been done, but it's not gone far enough in terms of really truly producing a single source of truth for any patient or citizen. And I think this is how we should be looking at it. It's not about what I want as a rheumatologist, or what Pete might want as a diabetologist, or what a vascular surgeon needs, or what a GP needs. It's about a citizen who can be in charge of their health just the way they're in charge, well or not, of their finances. We need to apply the same principles and put the patient in charge of what's happening and be able to coordinate their own care when a problem arises. Now, our strategy and our trust changed last year in light of lots of key reports. Safe Hospital, Safe Awards was the sort of back-end response to the need to respond to France's report in the main, and appreciating the need for technological advancement. And sharing information and interoperability is absolutely key, having common standards, improving the quality of data that we have, and enabling patients to be meaningfully engaged in that process. And we've got patients on our EPR steering and board to take things forward. So we've got a real challenge to be fully integrated now by 2018. That's been reaffirmed with a 5-year forward view. These were the other key documents, so the Berwick report, the Francis report, the Future Hospital Commission from Royal College. The Academy of Medical Rheumatology is a great document if you haven't seen it, published October last year, eye care, information, data and technology in the NHS, all talking about the need to predicate what we do around a patient and being patient-centred and not being based around the location of care or the disease that they're suffering with. And my fear is that as we modernise and go from paper to electronic, there's still a huge focus by specialties going down the route of, I'm a vascular surgeon and this is what I need. I'm an ophthalmologist and this is what I need. I'm a rheumatologist and this is what I need. Well, actually, I might see all 3 of those patients, or that same patient with 3 conditions. And, polymorbidity is the key thing now, chronic disease management. You don't see somebody with one condition, you see them with lots of conditions, and therefore you need that information because it ties in. I treat people who have eye complications of their diseases, so I need to be able to see the ophthalmology record. There's no point isolating and fragmenting the paper record into electronic fragmented records. And I think we need to learn, I like the concept of accountable care organisations. Simon Stevens, having been in America for 10 years, has been talking about this. And Jeremy Hunt talked about it a month ago after the release of the 5-year forward view. And I think it's got huge applicability, and I'll come back to it shortly. Now, monarchs and gout. We're going back to gout now. So, it's known as the king of diseases and diseases of kings. So there's 3 kings there. If you want to have a stab, you'll get a chance later to have a look at it. So I'll come back to it. Whilst this is a patient with an autoimmune connective tissue disorder called lupus or systemic lupus erythematosus, this is applicable to any patient. COPD, heart failure, asthma, diabetes, you name it. This web of care is what applies. And you realise how many people touch a patient, all of them, but at a centrality, the patient should have access to all the information they need. And if they haven't, we've got to ask ourselves why and what are we doing about it. So how do we fix it? Well, we've got to drive up quality and we've got to reduce cost. The 30 billion of savings has now come down to 22 billion of savings over the next 5 years with the 5-year forward view. I would say it's a no-brainer. You have to spend to save. We've got to invest in the infrastructure because there's no point propagating the models from car manufacturing in the Far East, Japan, the lean movement, unless you've invested in the technology. Those factories were state-of-the-art, that's why they could do lean. We can't do that without state-of-the-art information systems. So that's a predicated requirement, a prerequisite for us transforming care. And we've got to be thinking about tomorrow. We've got to be thinking about where do we want to be in 5 or 10 years' time when we have the obesity epidemic that's going to hit us. If we think things are bad now, the demand from society is only going to get worse. So we need to understand from the past that lab information systems, when they came in 20 years ago, were considered a luxury. They're now the norm. And in 5 or 10 years' time, electronic patient records will be viewed the same way. Just like having a mobile device that's a mini computer is the norm now compared to the boxes we had 20 years ago. But we need to do this quickly. Speed is of the essence. And your strategies, wherever you work, have got to be predicated on doing this as quickly as possible and not in the typical NHS way, which is watching paint dry and waiting for another generation to come along. We moved into a new hospital in 2006 when Nokia, do you remember Nokia? Funny word, isn't it? Dominated the mobile phone sector, and the iPhone was a rumour. I don't need to say more, that's only 8 years ago. And our lives have been transformed. I mean, the next thing that will transform is the iWatch. There's little doubt about that, and the way Apple are now moving into the health market, with HealthKit, etc. Some of that's starting to happen already at scale in America. So that's the future. So we need to play catch up, but we need to do it quickly, because otherwise we'll still be catching up in 5 years' time when you've delivered your electronic patient record. And delivering that is not the end point, it's the starting point to transform care. Kodak produced the first digital camera, but it was scared of what it might mean. Its business model was predicated on film, which worked in the present. The digital camera they produced 10 years before the next release of a digital camera, they never did anything with. And the rest is history. We're a Kodak now. So we've got to start connecting up, and we've got to be looking into the future and predict where we need to be, and not just be responding to the here and now. I'll let you just read that. Because lots of people have a problem with technology, and I repeat, I'm a clinician. I'm not I like the whole informatics world, but I am not a techno person at all. I'm not remotely technical. But this could apply to some of the messages I've had when I've gone around saying you need to start using electronic results acknowledgement now. It's not acceptable that you throw pieces of paper with results in the bin. And we established we've got over 11 million results that we couldn't prove had ever been looked at. 11 million results. Just imagine how many avoidable deaths or diseases would be amongst those. It's shocking. We now have a fully electronic system that does it. But it took a bit of work. It took me 3 months, but we did it big bang. In the process of 6 weeks, we went from no electronic recording to full electronic, 95%. And it was the first time it's been done at scale. But big bang is the way forward. But what this was referring to is 1834, the stethoscope, which had been designed 17 years ago, before that, in 1817, in France. So human nature is what it is. People react to change and they don't like change. They're comfortable where they are, but we have to change. And I think that change starts with us. It certainly starts with me. Now, you all know who this is, I'm sure. Anyone want to? Sorry? Yeah, Simon Stevens, Chief Executive of the NHS. It's great somebody knows, I know Pete's seen this before, but actually I've used these slides about 10 times and nobody's known who it was, which is pretty shocking when we're all working in the health sector, but I'll leave that one open. When he came over from America, having just been in America, I can attest to the fact that portion size are reasonably larger than I'm used to in the UK. And Simon Stevens was charged with, by number 10, with getting in shape. So he adopted the 5-2 fast diet, I understand, and he took control of his life. Whether there's an improvement there or not, he's obviously healthier. Some people say he doesn't look as healthy, but he certainly is. And George Osborne has famously recently not just put together a very lean austerity package with our finances, but has also leaned himself by doing the 5-2 fast diet. Now, anyone who knows me from of old will know that I'm balding a bit. I've certainly put on some weight. I'm not as healthy as I was. In fact, I would not say I define health defined by having psychosocial well-being as well as absence of disease. I'm not healthy right now. And I suspect all of you are not particularly healthy. We all work too long. We all work far too hard. We don't play hard enough. I don't spend enough time with my family. I ruptured my ACL playing football 18 months ago. And have I activated myself as a patient? Well, I have to say no, because I've been trying to propagate a vision of health for the health community. And so I've been working too hard doing that at the expense of my own health. And in 10 years' time, whose problem is that? Is it the NHS? Is it your problem to fix me? Or is it actually my problem to actually take control of my miserable existence right now and sort it out? And I would say we all have a personal responsibility. And as healthcare professionals working in the healthcare industry, we should be advocates and exemplars of healthiness for our patients to follow suit. Because there's no point me preaching to patients to do their physiotherapy exercises, to go and do yoga, Pilates, swimming, cycling, adopt a fast diet, get better sleep hygiene, stop doing emails late at night, switch off the screen, spend more time with their families, if I'm not taking that advice and heeding it myself. But we've got to do that. We've got to change behaviours, and that's going to be the key thing. Because we spend all our time talking about determinants of health being healthcare delivery. But actually, when you look at the field model of healthcare, stuff that's been around for 40 years, various studies have all responded in the same way, that you've got your genes, you've got the society you live in, you've got health and disease, healthcare, but that makes up about 10%. By far the biggest contribution to our health is lifestyle. and that's 40%. But we aren't focusing on it. We talk about it, but we aren't genuinely engaged with it. Well, a small minority are engaged with it. But every day, and any of you are healthcare professionals doing clinics, wherever it is in the community or a hospital setting, will have the same with patients who will come back and see you 6 months later with the same problem, back pain, knee pain, not having bothered to do any exercises. They're wanting me to write a prescription or inject a joint. That's not the answer. We've got to change the way we do things. These are really excellent slides. I'll point you all towards the King's Fund. It's got so much excellent material done here with the Local Government Association. But spending, when you look at spending in terms of local authority, if you're then looking at public health compared to the spending on healthcare, it's no wonder we've got no money. But actually there's loads of money in the system, it's just being spent in the wrong way. We've got to be focusing on prevention, not just reacting and responding to healthcare. And that spending is just exponentially increasing year on year, with more being put there. There's huge variation in inequality in the way that we spend that money. And it's again key that we try and reduce that variation and health inequalities, because it's quite startling. We know that there's going to be a doubling of the number of over 80 over the next 10 to 20 years. So these problems are going to continue to face us, and we need to find solutions for it. And I think this is fairly startling, really, the health inequality in terms of life expectancy between the north and the south. I mean, they talk about north-south divide, but you know, all of that investment over the last 15 years in the NHS, where's it gone? What's it done? Well, it's really delivered very little. There are improvements, undoubtedly, and this isn't meant to be a sort of morbid, depressive state pre-Christmas, but actually, we've got to do it differently, because the money is being spent in the wrong way, investing in hospitals and health care, rather than propagating personal well-being and health. And that's got to be the answer. So fortunately, I'm midlife, but I don't smoke. I possibly drink a little, but I don't drink too much, I don't think, but everyone says that. I exercise too little, and whilst I love cooking, I don't get time to cook because I'm having to get home and then do my day job, which is respond to emails and do results, etc., because my job plan is so appalling. So look at the statistics. 4 times more likely in the next 10 years to die. That's shocking, and we should all be shocked by that and be doing something about it if you aren't already. And maybe some of you are, and I admire you. I'm not, and I've got to. So this is a personal view. So lots of life years lost by avoidable things. We've got to start avoiding these things and take personal responsibility for it. Because the cost, when people say there's no money in the system, it's baloney. There's huge amounts of money in healthcare and social care. It's just all being duplicated and wasted. And we've got to aggregate all of that money into a fund that looks at propagating healthcare and health, but delivering healthcare more efficiently and effectively in a timely manner when needed. And the same applies for mental health, for musculoskeletal conditions, etc., etc. The list goes on. And when you look at ED being used as a drop-in centre, and certainly ours is, we have 190,000 patients attending our ED every year. Now, I know another trust, in fact, it's Addenbrooke's Hospital, has 110,000 every year. They're a similar sized trust. They think they've got a problem with 110,000 ED attendances. We have 190. And it's nothing to be proud of. It's not a statistic that we should be lauding and saying, well, we need 500 more staff. No, you don't. What we should be doing is halving the number coming to ED, because they shouldn't be coming to ED. Only 20% of them being admitted, and the numbers attending on a daily basis have gone from 400 to 550 in the space of a year. But look at the cost compared to being seen in the community by either a GP or a neurologist like me, or an extended scope practitioner or specialist nurse. An ED attendant, the ambulance that they call, because they've got no other means from a social care perspective, and the inpatient stay when they have it, leaving aside the cost to society for the last year of life. These are damning, but look at the cost if we start doing telecare for a year and see the patient in the right place. So there's huge savings to make, but more importantly, it will improve the quality of the care we deliver, and that's the key thing. So we've got to bend this curve on demand for the reasons above, and the most startling here again is looking to the future. 1/5 of all children are obese by the time they're in year 6. That's end of primary school. That's shocking. So we cannot carry on being the healer of last resort. We've got to really start avoiding and preventing and spending huge amounts of money on wholly avoidable illness that's predicated on abnormal behaviours. And we've got to educate and engage society as a whole by setting an example as well. The 5-year forward view very much talks about that. It's brought all the key stakeholders, and I'm going to, with time going against me, I'm going to rush through this bit really, but I'm assuming a lot of you will have read the 5-year forward view or heard much about it. If you haven't read it, you probably have read it before, because a lot of it has been said time and time again for decades. I heard it all when I was a junior doctor 20 years ago. We need a strong economy, we need integrated care closer to home because of the crisis with an ever-increasing population with more chronic disease. We've got to embrace innovation, and actually, first and foremost, we've got to embrace the given. The given is having electronic health records, because that's not innovation. It is something that is happening across the board in the USA and other places in developed countries. We should just be adopting that quickly. Doing it over the next 5 or 10 years as a roadmap is not good enough when there are solutions out there that would mean you realise the benefits within 2 years, and it pays for itself. It's like renewables. If I put a pellet boiler in and get rid of my oil, the government will pay me £6,500 per year for the privilege of doing so. And the payback time is 2.5 years, and after 7 years, I'd have £40,000 capital back to me. The same applies to electronic records. We just need to get on with it and not try and build it ourselves. Best of breed, from our perspective, this is a personal view, but a change of our strategy, best of breed, trying to interface and integrate everything, just is too slow. And we've learned our lesson over the last 3 years. We've changed our strategy, and we are going to procure an integrated solutions. That's the only way to enable us to get to the point where we can start transforming care, improving quality, reducing costs, and making savings. So these are some of the examples. So up in Yorkshire now, the certain vulnerable on their own have a big red button, and they can just speak to a nurse straight away. Contact lenses being developed to monitor diabetes, to monitor sugars. The amount of innovation that's out there is startling, and it's really, really exciting. I leave you with, I just recently visited Advocate Health. They're one of the largest accountable care organisations in the US, propagating population health management by a fully interoperable health information exchange between 50 or 60 different systems across their whole population. And by transitioning 40, well, they can identify, first of all, they can predict the 40% most likely to A, attend ED, and B, be readmitted. And by transitioning them to the right place, the saving is $237 million in 1 year. $237 million in 1 year. They've gone further. They now think that their savings are going to be between 30 and 100 billion pounds in 10 years. And that's just avoidance of hospital, before we look at all the other benefits. So the economics here is a no-brainer. We've got to invest to get there. We've got to save on the 500 billion, because I think the NHS has got fantastic staff. We just need to activate them. They've got great ideas. Those on the coalface know where the problems are. We just need to give them the toolkit, which is the technology enabling. And data from HS6 shows junior doctors spend 66% of their time looking for information about the patients they're caring for, and just 24% of patient contact. Well, I want to take it all back to the bedside. So we're going to get big screens that are on the end of the bed, which means patient care happens at the end of the bed, not in doctors' offices, not in nursing stations, because that's where it should happen. So there's plenty on integration between primary and social care, upgrading prevention, as we've talked about, and new models, really. We've got to implement new models of care, and that requires new delivery models, and we've got to do this quickly. But technology and an integrated, interoperable health record is a must to enable all of these things to happen quickly. And I think moving towards more of an accountable care type organisation setup is really important. They've also announced the National Information Board, and they articulated 3 challenges. If we don't get on top of health prevention, then we're going to hit a crisis, because the progress we've made with health qualities will start to stifle. The variation in health inequality will widen, and we'll just be unable to spend money on potentially beneficial treatments, because it will be crowded out by spending billions of pounds on avoidable illnesses. We've got to change, really invert the pyramid. We've got to care quality, we've got to change models of care, and we've got to fund, but that funding has got to be predicated on releasing benefits, something that the NHS does really badly, public sector does really badly. We've got to show that return on investment, and that will potentially sometimes be controversial in terms of the savings and inefficiencies new models will drive. There's got to be transparency, fully interoperable, we've got to move towards population health, we've got to use smartphones, we've got to engage patients in that process. I'm going to flick through some of this. So, famous painter who suffered with rheumatoid arthritis. I'll come back to it. This is a patient, just another unengaged patient. It took 7 years for this patient down in London. This is a GP in Camden kindly shared and allowed me to show this. Who was finally having leg ulcers dressed and was in renal failure before it was all picked up. Been to various EDs, they had lots of data about this patient, but none of it was joined up to meaningful information. Delayed diagnosis, poor outcome, 30-year-old. Why was that? Well, it was a non-engaged patient, wasn't activated, lots of discrete data but no meaningful information. He was using different EDs as the first point of care, and the GP mechanisms picking up that patient back at the GP practice failed on this occasion. It's a problem, but it would be solved by an integrated health record. So we need to diagnose, treat, prevent. We need to know our populations using technology, be able to predict those who are going to be in problems, because we know that 20% are most likely to be using 80% of resources. Those are the ones less likely to be engaged or activated, less likely to be using technology to improve their health and well-being. So we need to be able to support those, but leave those who are able to get on with it, because they will do. They'll be educated and know what to do. And that will take us from uninformed to informed citizens who can share decisions. Will be highly engaged and empowered, socially connected, and it will lead to a virtual, mobile, anytime, anywhere sort of philosophy, which I think is really key. And this is a sort of European model that's being propagated, but it's the same globally. Wherever you are, it's all about starting to focus on your populations so that we can keep people well, manage those at early risk by predicting them, but more importantly, start to manage behaviours, chronic diseases, and obviously with a focus on end-of-life care. But this should all be propagated on trying to keep people well in the first place. Just brush on this, again, the Price Fund paper, really good. It's about us reflecting on the contact we have with patients. When we talk about activating a patient, engaging them, we've got to change the way we have a personal conversation with them. So it becomes less task-based, because at the moment, we tend to be all about the task. What treatment am I going to give? We try and do a lot of that socio-emotional care talk stuff, but it's very difficult. My wife's cardiac care consultant, it's what they do. They do the opposite to what I do when I'm dishing out the next MRI scan or the next methotrexate prescription. We've got to change the agenda. This was a reflection list for GPs, but I think it's applicable to any healthcare provider, wherever you are. And it's worth us becoming more effective practitioners, because that way we can start to engage, have the time to educate and engage patients in the process. So we've achieved a lot. NHS is ranked number 1. When you look at the data from the Commonwealth Fund, it's actually not that great. I mean, when you look at some of the stats, we aren't fantastic. Yes, it's number 1, but that's nothing necessarily to be proud of. I'd urge you to look at that data if you haven't already. It's got to be digitally enabled. So, lots of ways to engage patients, apart from contact time, but we've got to make it easy and functional for them, so you have patient portals, advertising, tax regime, incentivise employers, get NHS trusts and the workplace to have a swimming pool or exercise to enable people to actually do some exercise. I'd love to do that at lunchtime, whatever lunchtime is. I don't have a lunchtime, but that's the point. I need to be more engaged, and we've got to stop using work as a barrier to that. We've got to activate patients. I'm going to brush over this, but it's absolutely key. We need to activate patients just as we need to activate ourselves as healthcare providers. And it's a very powerful message that shows that those who are activated and involved and want to contribute to their own health do better than those that aren't. It's a no-brainer really, but it's a very complex model. We need to be exploring that in far more detail. And there's four levels, and it's really, really key that we start focusing on those who are less activated, because that way we can really start to turn the tables on behavioural change. And that feeds into the World Health Organization. Edward Wagner done a lot of work here on chronic disease management, because I think, certainly as an oncologist in my specialty, I have continuity of care with my patients. I've been looking after them now, some of them for eight years or more. and I've seen quite a lot of them with complex disease who pass away and have that relationship with families. I'm very much a palliative care specialty, very much like primary carers, and we need to have informed, activated patients, and that's absolutely key as we start to deliver new models of care. I'm going to brush over the pioneers. Disruptive innovation. Steve Jobs is the best pioneer. The way we've moved from mini computers to from mainframe computers, etc., made it more mobile. Great examples there. But speed is the essence. We've got to do this quickly, and we've got to use insight. So to finish with, my insights over the journey that we're travelling at the moment as an organisation. It's all about people. These are clinically led programs of change that have got to engage patients. They're predicated on having good technology, but the technology is not the be-all and end-all. It's the starting point by which we then transform the way we do things. There's unfortunately inevitable politics with all of this, but we just have to carry on singing from the same hymn sheet to join up health and social care, and we need to get organisations to do that more readily. Because NHS leaders are great at running organisations, but they don't run systems of care as patients fall in and out from primary care to secondary care to community care to social care, etc. We've got to blaze a trail because really full proper integration has not been done yet. But the NHS is set up to do it. And the Americans are envious of our NHS unique identifier because they have nothing similar in the States to do that. And as I've alluded to, there's lots of money in the system. Road traffic accidents cost £34.8 billion to NHS and allied public sector services each year. £34.8 billion avoidable accidents. So we need to focus on the small proportion, that 20% who's utilise 80% of resources. We need to put in case management, care coordination, caseworkers to help them, invest in the electronic record, but most importantly, engage patients. It is all about the patient. We need to, I think, move towards an alliance. We've got to get rid of transactional bases, commissioners, commissioning services. There's lots of big pots of money. Let's just share them and share the risk so we actually put the patient at the centre of it and activate them to be involved in their healthcare. And we need to focus primarily on health and well-being. Change management is key. Speed is the essence. We've got to be looking to where we need to be in 10 years' time, and getting a patient record that's electronic in 10 years' time will mean we're just playing catch-up as ever. I love everything Steve Jobs has touched, really, and this is one of his favourite phrases. Everyone makes the NHS complicated, and it's not. It's about a person, a citizen, you and I, who might have a problem and need to go and see somebody about that problem and find a solution, and be able to contribute to that solution in a meaningful fashion. Medicine is dead easy, and it's the simple bit of my job, and the joy of my job and the reward is seeing patients. Dealing with the politics is the difficult bit. Thomas Sydenham was the person who said that. So, father of English medicine described Sydenham's career. Louis XIV, Emperor Augustus and Henry VIII, famous kings who've had gout. Rubens, Flemish painter, famously had rheumatoid arthritis, and you can see increasingly drew patients with crippled joints in his paintings. I'm going to flit over that. So the mission that we've set ourselves at UHCW is to deliver a patient-focused, a citizen-focused, fully integrated digital care record, accessible, everything, anytime, anywhere, by anyone, but most importantly, the patient in its entirety. We've got to engage and empower the patients to use that and focus care coordinators, those least able to or more vulnerable, and enable them to be responsible for and manage their own health, to become healthy. I won't be having a heart attack in 10 years' time, I won't be hypertensive, I won't be going to see Pete, because I'm going to take control of my own health. We all need to set that example. And we can deliver world-class care by enabling proper innovation, to move away from the paternalistic hospital setting of care and actually leave hospitals for very, very sick patients and people who need operations, and actually focus the majority of healthcare which can be delivered closer to the home. And hopefully by doing that, we'll become the healthiest community in the UK. Thank you very much for listening.